Hello, everyone. Hello, hello. Thank you for staying until, I know it is almost 5 o'clock, and so we will keep it short and sweet and also quite engaging, so it will be really fun. So we have a star lineup here, and I'm really happy to welcome you to our panel, The Use of Secondary Data and the Goal of One Health. My name is Tugce Schmitt from Maastricht University, the Netherlands, and I am the moderator of this panel. I have background in public health and public policy, worked in several national and European digital health projects, focusing both on country context as well as the EU aspects. In our panel today, we'll explore how health data can not only shape more holistic and integrated approaches towards One Health, but also revolutionize how we develop, test, and evaluate medical technologies. We begin with a presentation on the European health data space, presented by Paul, and how it can serve as a foundational tool for advancing One Health objectives. Next, Moira will talk about antimicrobial resistance, another timely and critical topic. We'll hear how innovative cross-sectoral approaches can help tackle one of today's most pressing public health threats. Finally, Alex will dive into the world of in silico regulatory science, a fast-emerging field using virtual simulations to transform healthcare innovation. Each of our speakers bring a unique perspective on how to unlock the full potential of health data and link this with the overall aim of One Health. I look forward to a dynamic conversation and your questions afterward. Let's begin with our first speaker, Paul. As you may know by now, Paul is a law professor at the Free University of Brussels. He is an expert in legal and ethical issues related to the use of health data. His expertise includes data protection, privacy issues, AI, and the secondary use of health data. At the VUB, he founded the Health and Aging Law Lab. He coordinates research on such issues through a range of international and national consortia. Before entering academia, Paul worked in the legal industry in the UK. He holds a degree in European and International Law from the Institute of European Studies in Brussels. In addition, from the University of Sheffield, he holds 2 degrees, one in law and the other in biochemistry. Paul is an Irish citizen and has lived in Ireland, the UK, and Belgium. His presentation is entitled, How Can the EHDS Help Us Move Towards One Health? We will talk about how the EHDS will facilitate the secondary use of electronic health data. We look at the minimum categories of data for secondary use in Article 51 and in Article 53. And we finally look at the challenges in health data access bodies and data holders. Paul, the floor is yours.
Thank you very much. And thank you very much for that comprehensive introduction. You reminded me things about myself I've actually forgotten. Thank you, everybody. Thank you for waiting. It's much appreciated. And this is a real novelty for me because the last few health law conferences I've been to, there have been 10 presentations on the EHDS. So it's really fantastic to get to the end of the day and only have had maybe half a presentation, and then there's me, so I'm sorry to spoil it. And it's a very interesting opportunity for me because I've been looking at the EHDS for a while, like many legal scholars, interested in health data. But I am new, I will be honest with you, to the concept of One Health. I've only started looking at it since the organization of this symposium. So it's kind of pushed me to look at the EHDS in a little bit of a different way, from a different angle. And that's basically what I'm going to go through in this presentation. So obviously until now, I've been completely focused on the issue of human health. So now this is just a quick look at what the EHDS means for One Health. How far will it allow us to go in achieving the goals of One Health? Can we expect a lot of it, or should we be realistic in what we expect? So as you see here, I will basically look at the categories of data that must be shared, and I will look at some problems around the definitions and what this means for One Health. So, first of all, quick recap. This will be a revision for a lot of you, but the use of secondary data is essential to One Health. It's essential for a number of reasons. One of them is integrated surveillance. And of course, the concept of One Health we know already, we've heard about it a lot today, it's very multidisciplinary. It depends on a lot of data from various sources and in a continuous way. So we obviously are talking about human health data, animal health data, environmental data, and there will be other categories of data, but you get the picture. It will hopefully allow resource efficiency through collecting new because collecting new primary data is very expensive. The availability of secondary data and the use of AI-powered computing will allow us to meet the goals, in theory, of One Health in a more efficient way. And also, it allows trend analysis and prediction. The availability of large amounts of longitudinal data allow great opportunities. It allows informed policy making, etc. And last but not least, this cross-discipline collaboration that until now has been somewhat lacking. We've heard the word silos many times today, but the goal of One Health is to break these down. So the current state of affairs, some European countries have great systems for the secondary use of health data. We had a speaker in the first panel talking about the system in Denmark. Many Scandinavian countries have great systems. The UK has, we were talking about the UK Biobank. Many other Europeans have great systems. These systems can vary though. Even in Scandinavian countries where there are great secondary health data resources available, there are some issues. For example, people outside of Scandinavia may find it hard to get access to those data. There may be barriers in place, even for Europeans. And then elsewhere in Europe, the availability of such resources varies quite considerably. So you have some countries where there are great resources and some countries where they are not, frankly speaking, not so great. Even where they do exist, the structure of them, the administration, the administrative barriers you need to go through are quite heterogeneous in nature. So it's difficult to have a one-tailored approach to using it. And of course, this creates difficulty. If you want a lot of secondary data quickly for whatever purpose, including One Health, if you have to tailor your technique in getting this data from various places in different ways, it creates obstacles. And we were talking about the system for sharing of health data. The system for sharing of non-health data, which I'm not going to go through today because we don't have time, is even more heterogeneous, even more varied. There is less homogeneity in the sharing of non-health data. So what am I talking about? Environmental data, data related to pollution, urban living, all these factors, socioeconomic data, all these factors that will be useful in addition to health data for human beings in striving towards the goal of One Health. Of course, as the previous speaker from the EU Commission stated, we can hope that in the future we are moving towards a more optimistic direction in this area, given that the establishment of data spaces, including outside the area of health, will hopefully intensify, allowing for more sharing of non-health related secondary data that may be useful for the purposes of One Health. But at present, we can say there are serious impediments. So that creates the question, what is the hope behind an EU approach? What is the hope behind the European health data space? Well, one is that the availability of health data is crucial for One Health, and that the EHDS, by making this data available, will boost the One Health approach. The greater the scale, the greater the efficiency, synergies, we'll have more uniformized processes for applying for use of this data, more uniformized conditions for the use of the data, etc. And of course, we've heard this also, that the most ambitious approaches, we heard it from the second keynote speaker, to break down the silos, sometimes you need legislation, compulsory legislation. So this is the hope. So now looking at the EHDS from a One Health perspective. Firstly, a quick recap, what is the EHDS? I'll be very brief. It is a regulation that came into force on March of 26, and it has two key elements for those who don't know. Improve the sharing of priority elements of electronic health records, and to improve the sharing of secondary data for reuse. This is what we're focusing on today. And so the key question in the remaining part of the presentation is how much in the design of the EHDS will we find an approach that is tailored towards One Health? So essentially, to cut to the chase, we will go to Article 51. Why? Because there are described the minimum categories of data that data holders must make available for potential reuse. There are steps to go through bodies called health data access bodies, but we won't go into the detail today. And looking at these categories tells us some interesting things from the perspective of One Health. So if we look at some of the categories, there are many that are essentially related to human health. I'm not going to go through them, but all of these are in some way or other related to human health. What you see about them, they're often quite precise. We all know what EHRs are. They're usually legally defined. A lot of these other sources are legally defined, registries, clinical structures. So you have concrete legal backgrounds often with useful definition, with clear definitions, etc. So these are very useful, and these will be very useful for providing secondary health data for a range of processes, scientific research, but not only. And this will help drive towards One Health goals. But we know that human health data is only one element of the picture of One Health. One Health depends on this multidisciplinary access to many forms of data. So if we look at the non-human health elements in Article 51, we see these two primary areas. So one of the categories is data on factors impacting on health, including socioeconomic, environmental, and behavioral determinants of health, and data on pathogens that impact human health. And we can make some interesting observations, because at first glance, this is very important. Some of these things seem very broad, but when you break it down, when you look at it in a little bit of detail, and when you look at it in combination with some other parts of the EHDS, you see that there is reason to be a bit concerned from the One Health perspective. So initial observations, there are many categories related to human health. They're much more precise. And there are only two categories that are really not at all related to human health, or two categories that will serve this non-human health need for One Health purposes. And what we see is these categories are not as precise. So what do I mean by that? If we take the first one, data on factors impacting health, including socioeconomic, environmental, and behavioral determinants of health. First of all, what does environmental mean? Does it refer to climate, pollution, sound, livability of cities? What can we find in the regulation? And we'll come back to that in a moment. And then the concept of socioeconomic. Well, you've often heard the joke, ask 5 lawyers a question and you will get 6 answers. Ask any social science, what does socioeconomic mean? You will get a very big and different answer depending on who you're speaking to. So where do we draw the line? This question of definition is very important. Why? Because if you read the EHDS in a maximalist, almost utopian way, you incorporate potentially an enormous amount of data. And you have to realize that behind the law, there are pragmatic realities. You have healthcare institutions, hospitals, research institutions, all the other institutions and bodies that the EHDS may apply to. They're going to have to collate this data, catalog it, render it in a form that will make it potentially accessible. They're going to have to do this in a pragmatic way. These institutions don't have infinite resources. They're going to have to start somewhere. They're going to have to prioritize. So it is helpful to know where to do this. So one of the concerns here is that these very, very broad elements are not at all or not well defined in the regulation. So where can we look for some help in terms of definition, in terms of environmental factors? We see some guidance. Pollution, radiation, the use of certain chemical substances, which is a very strange phrasing. But anybody who has the most basic legal training looks at the wording here, such as, being very important. These are indicative, they're not exhaustive. So this potentially can include many, many other factors beyond this. So I would submit that this guidance in this recital is of limited value in interpreting what environmental means. That might sound good from a maximalist perspective. You think more data, more research, more One Health, whatever. But remember, these organizations exist in this pragmatic reality where they're going to have to prioritize. And I would make the argument that this makes it difficult to do that because it's hard to know what is excluded. There is also another factor concerning the nature of the data holder which renders this much less expansive than it appears. Concerning socioeconomic factors, nothing. There's no real definition, no real guidance, which is very problematic. And then looking at data on pathogens that impact human health. This initially seems very interesting because obviously One Health is concerned with all kinds of pathogens, as we will hear in the second discussion in our panel. But not just, of course, pathogens that affect humans, pathogens that affect animals, plants, etc. And there is some guidance here. It's quite encouraging from the One Health perspective because they're talking about non-personal data, so this lends credence to the use of other forms of data that could be relevant for One Health. And you see the inspiration stemming from the COVID pandemic, which of course is also a boost and an inspiration for the One Health concept. But it seems clear that the concept relates to organisms that are pathogenic for humans, not animals or plants. Perhaps we will get guidance later that expands this, but the reading I see now, this is not the case. So again, the guidance is non-exhaustive in terms of human pathogenic data, which is not a problem, I guess, but it seems to refer to human pathogens. So it seems that it excludes pathogens relating to human health or animal health. Again, it's important not to be facetious here. We talked about in the earlier panel, the European health data space is the first data space in hopefully one of many. So it probably is a bit unrealistic to expect it to include everything. But nonetheless, this lends weight to the argument that the EHDS will be a limited tool to a certain extent in the achievement of One Health, etc. And now, another important issue which will actually limit some of these potentially far-reaching definitions in quite an alarming way, I would submit, for the concept of One Health. That is the concept of a data holder. What is a data holder? A data holder is the entity that holds data that is subject to the obligation of making the data available for secondary use. If you're not a data holder, but you hold this data, you're not obliged to make it available for secondary use. So the definition of data holder is quite important for the concept of One Health. Why? Because if you look at it closely, it seemingly excludes a number of entities or many entities that will process environmental data, socioeconomic data, that would be useful for the concept of One Health, but they don't fall within the definition of data holder according to the EHDS. Why do I say this? Because of this type of wording here. A data holder is not just a body that holds that data, it's a body that holds that data that is usually based in the healthcare or care sectors. That will, without doubt, capture many bodies, public health bodies, etc., hospitals, research bodies. But there are many bodies that will be processing this type of data that do not fall within these traditional sectors, that don't have a health or care remit, and seemingly these fall outside the definition of data holder, and they will not be subject to the requirement to make their data available for secondary use. And from the perspective of One Health, this may seem somewhat unfortunate because it means that the EHDS may appear a limited tool. It is a tool to achieve the goals of One Health, but it is somewhat limited because it excludes some forms of data that are very important, and it excludes the application of the EHDS to bodies that would have a role in the One Health concept. On the other hand, you have to be realistic. It's arguably essential from a pragmatic perspective to limit the EHDS in some way. It is a health data space. It's not an everything data space, nor should it be. So there are good reasons for what we see. I think I can skip through some of this to save time. This is what I was saying. Many agencies will not be caught by the definition of data holder, even though they do process data, for example, in environmental or socioeconomics that could be useful for One Health purposes. So essentially my conclusion would be that the EHDS should be viewed as a tool, but no magic bullet. In addition, there is uncertainty. There's a problem of potentially unneeded costs. And then we have the issue of perverse incentives as well. But given we're running late, I'm going to cut my presentation short here. I want to keep the message conceptually simple, and I want to give space to my fellow speakers. Thank you very much.
Thank you very much, Paul, for this informative presentation. I saw, I think, many question marks in your presentation, but nonetheless no exclamation mark, which is really nice. And we will discuss this topic after all the presentations. And my next expert is Moira. Moira is a veterinarian, graduated from the University of Cambridge with a PhD in genomics and epidemiology from Ghent University, as well as Broad Institute of MIT and Harvard. Since 2022, she has been working at CNSano, the Belgian Public Health Institute, as a senior data scientist and epidemiologist. Moira is the One Health focal point for AMR at CNSano. She coordinates the Belgian One Health surveillance of AMR network, called BELMAP, and through the EU GEMRI2 project, she is the co-lead of a joint action developing integrated One Health surveillance of AMR in 18 participating countries across Europe. Her presentation is entitled The Challenges and Opportunities of Secondary Data, Antimicrobial Resistance as the Poster Child for One Health Approaches in Public Health. In her presentation, she will talk about how AMR exemplifies the need for One Health approach, given its complex, diverse across human, animal, and environmental sectors. And then she will touch on how national and international efforts are increasingly calling for integrated surveillance to tackle AMR. And she will also discuss the methodological challenges. And at the end, she will present some innovative solutions for data sharing and harmonization. Moira, the floor is yours.
Thank you very much for this nice introduction and the opportunity to talk to you today. Yeah, I'm really delighted to be here talking to you about secondary data, because when you say we're going to be presenting some innovative solutions, it's kind of a bit more of a call to action. We heard in the keynotes this afternoon about how I think a lot of people working in public health are really calling for people working in law and technology to bridge some of these gaps, and that will be sort of my future perspectives. But yeah, I'm delighted to be here talking about the use of secondary data. I'm going to give a slightly different perspective as a scientist who every day is trying to apply a One Health approach to a public health issue and is using secondary data for this. And because I think it's fantastic to be talking to a room of such diverse backgrounds and experiences, but sometimes it can be better or easier to understand concepts using a concrete example. So I'm going to talk about this all in using the example of AMR. So to give you a quick overview about what I'm going to present today, I'm going to start off about just introducing AMR and why it is such a good example. You've already heard it's really a quintessential One Health issue. And then I'll be talking about, as Paul did a fantastic introduction to this, at the moment, One Health approaches in public health basically means secondary data. Because it's cheaper, we already have data from a lot of surveillance programs, but this comes with a number of challenges. So I'm going to try and give you a better understanding of what issues we're facing and how we're trying to overcome them, and looking to the future, sort of a call to action of what we need to be able to do better analyses and to apply a One Health approach more efficiently. So I'm going to be giving the case study of AMR and why should you care about antimicrobial resistance. So this is the development, the phenomena of bacteria, fungi, viruses, pathogens that cause disease becoming less sensitive to the drugs that we use to treat them. And this is actually already estimated by the Global Burden of Disease study to be the 3rd leading cause of death globally. And it really is a global problem. It disproportionately affects lower and middle income countries. But in 2019, 540,000 deaths were estimated to be associated with resistant infections, and that's 35% more than the Eurostat estimate of mortality due to COVID in 2020. So this is already a crisis, and we have very strong evidence that it's getting worse. And a number of factors mean that it's predicted to be accelerating. So for example, older individuals, for various reasons, are more vulnerable to resistant infections, and we have an aging population in large parts of the world. Also, a number of the factors associated with climate change, so extreme weather events, mass migrations, conflicts, these are all also associated with accelerating the development and the spread of resistance in pathogens. And the truth is this is compounded by the fact that it's really hard to slow or remove resistant trends. So one of the main drivers, one of the reasons that pathogens become, microbials like bacteria, fungi, viruses become resistant is because they're exposed to the medications, to the drugs that we use to treat them. And it's much harder to develop resistance than it is to keep it. So while the threshold to develop resistance in the first place might be quite high, for us to be able to remove that resistance is really difficult. So it's hard for us to slow or change these trends. So if it's difficult to make the bugs less resistant, what we need is new drugs. But the truth is, we don't have very many new antimicrobials in the pipeline. So this really is a huge crisis, I think, globally. And so I think, we should all be aware of what's going on. And this is a One Health issue. In fact, working in public health, sometimes I hear the complaint from my colleagues that when you say to a politician One Health, they say, oh, AMR, because the two terms are so closely associated. And that's because it's a perfect example. So both the drivers of resistance, these drugs and the residues of the drugs, they're present everywhere. We take them as humans, we use them in veterinary medicine, they're applied in agriculture. They're constantly exposed in different environments. And the drivers of resistance, so the bacteria that are causing the disease, the genes that allow them to be resistant, they're also ubiquitous. They're present, in human medicine, on animals, in the environment, and these are all interacting and spreading. And what that means is, if we want to tackle the issue, we can't just focus on human medicine. We will still have a flow in of resistance from the other sectors. So to get a good idea of what's going on, we really need to know what's happening in terms of resistance in all of these different sectors. And given that we already have monitoring in the sectors individually, the easiest way to do that is to look at all that data that already exists. But the problem is that surveillance of AMR is incredibly fragmented. So on the left-hand side here, you can see just a selection of the reports that are produced every year in Belgium containing data on antimicrobial resistance and consumption in the different sectors. And each of these reports can be 30 or 50 pages long. So getting a clear overview or even finding the most appropriate data is really difficult. So the first thing we're trying to do in applying a One Health approach is just to bring everything together in the same place and using a common language so that we can actually understand what's happening in the different sectors relevant to each other. But obviously, because we're using data from other surveillance programs, we're using secondary data, and that comes with its own challenges. So the truth is, each of these surveillance programs was not designed to give us an idea in terms of One Health. They were designed to measure different questions. And that means that they use different metrics. They might measure different pathogens, different bacteria. They use different drugs. They use different definitions. So for example, when a doctor talks about a multi-drug resistant bacteria, that might mean it's resistant to 3 antibiotics tested out of 5. But in veterinary medicine, we test 11 antibiotics, and it's resistant if it's more than 7. So, and actually in different countries or even in different laboratories, they'll use different definitions, and so it's very hard to know that we're all talking about the same thing. They use different sampling strategies, they use different methodologies, they use different ways of deciding whether something is resistant or not. For the nice thing is in human medicine, we have UCAS protocols, so within Belgium, 98% of labs use exactly the same methodology, and they have the same cutoff to say this is resistant or not. But we don't have that in veterinary medicine. So each different laboratory will be potentially saying, if one bacteria was sent to one laboratory, it could be resistant, and from another, it wouldn't be counted as resistant. And that makes pulling all of this data together and doing meaningful analysis really challenging. So for example, the first thing we need to do is really find a common language so we can compare the data and speak about it. And here I'm presenting you with some consumption data. So this is the volume of antimicrobials that was consumed in Belgium. On the left-hand side, you have in human medicine, and on the right-hand side, you have in veterinary medicine. But in human medicine, we use it in terms of defined daily doses, so the average dose for a 70-kilo human per 1,000 inhabitants per day. And on the right-hand side, you have the same measurement, but for animals, where they use the milligrams of drug per kilogram of the total animal population. And if I were to ask you which population is using more antimicrobials, I don't think you'd be able to answer. They're completely different metrics. It's impossible to understand what they're doing in relation to each other. So what we have to do is we have to find a new metric that we can use for both. So here you can see it in terms of just volume of active product. We also have metrics that do take into account the size of the population. But here you can see, for example, the green bars are the veterinary sector, the multicolored bars are the human sector, and actually we have huge reductions in the veterinary sector. And last year, for the first year in Belgium, they actually both consumed the same volume of antibiotics. And to be able to make this comparison, we need to develop new methodologies, we need to combine new data sets. The problem is each of these data sets obviously come with their own assumptions, but we need to make these efforts to be able to bridge these gaps. A second major challenge is data quality. A lot of the time, the data that we receive when we use secondary data is aggregated data and possibly already interpreted data. So, as maybe you all know, with aggregated data, one of the problems is you lose detail. So, for example, looking at these two graphs, on the left-hand side, you can have the proportion of isolates in cattle that are resistant to colistin. So this is E. coli, a common bacteria that's ubiquitous. And colistin is a really important last-line medication to treat gram-negative bacteria. But essentially, if you looked at this, you'd say, we see higher resistance in cattle than in humans. But when we look at it with a little bit more granularity, we actually see that in healthy cattle, we have lower levels. But in sick cattle, we have very high levels. And in young cattle, so in veal calves, we see higher levels than in older cattle. And so, the more detail you can do, the better the picture you can paint and the better you can understand the patterns that you're seeing. But the truth is this is still aggregated data, so we still get it as a proportion of isolates tested that were resistant to a specific antibiotic, and we receive it aggregated per antibiotic. And this limits our statistical power, because basically it means that we have to model, for example, each antibiotic individually, but we know that co-selection, a lot of the time if a bacteria becomes resistant to one antibiotic, it might become resistant to another. And, that's not a problem in and of itself, but it just means that our models are less accurate. And obviously the point of this data collection and this analysis is for us to better understand, for us to better model, which interventions are working, where the risk factors are, what we should be doing to minimize the impact. And if we don't have accurate models, we can't serve that function. Another problem is that we receive it as interpreted data. So, we're told what proportion we're resistant, but we don't know whether they're defining resistance using the same terminology or the same methodologies. And these two factors, it's great to be talking at this conference about it, because actually when we talk to stakeholders in various European countries to say, is it possible to get better data, to get raw data? And actually it really is technological and legal limitations that are impacting the possibility to share raw data. Another key factor is the loss of contextual knowledge. And this is huge when working in One Health, because the problem is you have people who are just working in contexts where they don't know what's going on. And we've all seen this, right? Like you read an article written by a journalist that's on an area of your expertise, and you say, oh yeah, but that paper, it didn't take into account this limitation, or it had this fault in the methodology, and you're very critical. But when you read a paper about something that you know nothing about, as humans, we're quite inclined to believe it. And so the problem is there's just a large body of evidence that shows a bias for overconfidence in data when it's in contexts that we don't understand. And that's a real problem if you then end up doing analyses that are actually inappropriate. And again, it's great to be talking about this here because at the moment in this project that we're leading in terms of trying to develop integrated surveillance across Europe, we performed a SWOT analysis. So we asked participants from 18 different countries to identify the strengths, weaknesses, opportunities, and threats in terms of applying a One Health approach in their country in surveillance. And here you can see highlighted in yellow all the times that they said that in some countries, legislation and technology were a real strength and provided huge opportunity. They were bridging the gaps and allowing effective application of One Health approaches. And in other countries or in other settings, it was a weakness and it hindered the possibilities. And so, we really need these transdisciplinary collaborations to enable those countries, or those situations that are struggling to be able to develop. So I've outlined some of the challenges that we face. How are we getting around this at the moment? So the first thing that we're really trying to build is intersectoral collaborations. So in terms of our One Health surveillance, when we bring together the data from all of these different surveillance programs, we don't just bring together the data, we bring together the people who collect all of this data. So on the right-hand side here, you can see all of the people that contribute to our One Health surveillance network. They all have to approve all of the analyses that we do, and that means that we keep the contextual knowledge. We shouldn't do any analyses that are inappropriate. But obviously, this is very time-consuming, and in some settings, it's just not appropriate. Another sort of key step forward is international collaborations. We see growing collaboration, as we've heard a lot about today, between international organizations working in different sectors. So ECDC, EFSA, and EMA, they produce One Health reports, like the GIACRA report. They also produced guidance on finding a common language, so they identify these key indicators, so key measurements that could be taken in different sectors to try and give a clear overview of AMR and AMC across sectors. We're currently in the process of updating that as part of EU JAMRAI, which is an initiative where we're bringing together 120 partners from 30 different countries. We also have models like the WHO model for integrated surveillance on AMR, and we're getting input from the quadripartite technical group on integrated surveillance on antimicrobial use and resistance. So within public health, we're trying to collaborate and learn from each other and find solutions around these challenges with secondary data. But looking forward, when we as public health scientists and also when we talk with other stakeholders like policymakers, really the call for innovation, both in terms of legislation and technology, is clear. This is, I think you're our hope. When we ask what's needed to be able to really implement an effective One Health approach, people are asking for innovation to data collection and sharing, especially things like technological solutions for point of care data collection. Our healthcare workers are overworked. To be able to collect patient-level data, we need to find ways of being able to collect the relevant data without really increasing the burden on them. I think within One Health, genomic data is really seen as the way forward because, of course, in this case, DNA itself provides the common language. DNA is the same across sectors. And in some settings, it's already shown to be working very well. But in some settings, we still need innovation to make the analysis, harmonization of pipelines, centralization of the data possible. And especially in terms of data linking. And while I've focused on the technological part, because I think as a scientist that's a bit easier to understand, the legislative part is huge in this as well. A lot of the problems, a lot of the limitations to data sharing is because the data was collected using a data sharing agreement, and secondary use for One Health purposes is not included in that. And so when we talk to our stakeholders, really the quote that I keep hearing is that the biggest barrier is a lack of a clear legal mandate. And while we might have a clear mandate and legislation to support the collection of data within certain sectors, at the moment, in terms of One Health, that's really lacking. And so, I think I'll leave that as my final sort of call to arms, call for action, that I think these steps forwards, these multidisciplinary collaborations, it's not just would speed it up, it's necessary, it's fundamental to being able to effectively apply a One Health approach to improve public health.
Thank you very much, Moira. Clear legal mandate, clear governance, so these are things that we want to see, hopefully, looking at the presentation of Paul, so I doubt if it will come from EHDS, but maybe from also other different sources that we can discuss after the last presentation. So my third expert is Alejandro, Alex. Alex holds the bicentenary Turing Chair in Computational Medicine at the University of Manchester and is a Fellow of Royal Academy of Engineering. He is an international leader in computational medicine, specializing in medical imaging analytics and in silico clinical trials. His work combines AI, mechanistic modeling, and regulatory science to transform healthcare innovation. Alex pioneered the development of AI-enabled image analysis methods, including the widely adopted Frangi filter, as in his surname, and has made significant contributions to population imaging analytics through the UK Biobank initiative. As the Executive Director of the UK Centre of Excellence on In Silico Regulatory Science and Innovation, Alex leads national efforts to advance in silico approaches in regulatory science. His presentation is entitled Harnessing Health Data for In Silico Regulatory Science, Transforming Healthcare Innovation. Alex, the floor is yours.
Thanks a lot, Tugce. It's really humbling as an engineer to be in an audience with people from other disciplines, but I learned a lot today, and I hope that my talk will provide some. I fully agree with Moira that having exemplars is really important, and particularly when things are cross-sectorial, because you need to have like a focal point that centers the minds of everyone. And I'll try to provide some examples in this particular context. So, in reflecting on the day of today, I was thinking that Manchester combines the three elements of this conference in the sense that was the origin of the NHS, of the National Health System in 1948, was the place where in the UK was the first computer being built, the baby was called, and where Turing was hosted, and also is where the suffragette movement and a lot of the social movements that happened within the UK were sort of originated. So it brings all of the different areas, and that was actually quite an inspiration as well. So the first mandate from every clinician is what is called as the Hippocratic Oath, and is that the first thing you need to do is not to harm. Now, if we look at how we develop innovations in medicine, whether it is drugs or it is medical devices, there are fundamentally three sources of truth, three sources of evidence to around safety and efficacy. So basically, scientific evidence on safety and efficacy is what we talk about regulatory evidence. So you can do that through bench testing, through animal testing, and through human testing. And it's important to remember all three of them, including human testing, including randomized control trials, they're models. They're models of some sort. Just to be more specific, in the case of human randomized control trials, they're a model about what happens in the general population when you test in a small subgroup of subjects. Now, how good those foundations upon which most of the innovations are built are. And I want to show you some facts that I think are going to be quite interesting and shocking in a way. So there's a journalistic investigation study that is called the Implant Files that show that over a period of 10 years in the US, 10 medical products alone produce about 83,000 deaths and 1.7 million serious adverse effects. These are products that went through the whole regulatory pathways that we have nowadays. So this is not like experimental technologies. This is real products on the market. In the UK, there is something called the Cumberletcher Report that was published a number of years ago that actually revealed how fractured the health and care system in the UK is, that you can actually find situations where you put people at harm. And this was particularly looking at three specific innovations. And it's actually heartbreaking to listen to about 700 hours, not I've done all of them, but 700 hours of witness evidence that has been recorded after anonymization is available online. The other thing that also so this is when the products are in the market, they produce harm. But what happens in the process of getting them to the market? So the left table represents medical devices. The right one represents to pharma. So what this table says is that for every 100 medical devices that go to the testing pipeline, only 30 of them will ever, in the US, only 30 of them will ever see the market. So 70 of them will somehow not pass all the tests. And that means that from the 100% of people that are participating in all of those studies, about 41% of them will remain with a device that is going to be investigational for the rest of their lives. And this is just the testing pipeline. And for pharma, it's even worse. So it's about 5 products over 100 ever see the market, and it's 68% of the people who were tested in trials will remain having drugs that will never be markets. So a big problem. So the first is an ethical, I would say, imperative, but then there is also an innovation imperative, and economic and financial imperative. So getting a device or a drug is on average between 14 to 16 years of R&D, and is, $500 million if you are talking about a medical device, about 2.3 billion if you're talking a drug, and that's the average cost. So it's not safe, and it's not cost effective either. So, and all of these costs end up being rolled out in our care systems and our insurance systems in one way or another. So what I'm proposing today to you is one aspect, like a fourth dimension of evidence, which we call in silico evidence or computational evidence. We call it in silico because it's on computers, and computers are mostly made of silicium, right? But you could also talk about computational modeling and simulation. And sometimes people talk about digital twins. Digital twins is a technology to generate models upon which we can do models and simulations afterwards. So what we are proposing here is that if you look at the horizontal axis, this is the life cycle of a medical product, and the vertical axis is the number of problems that you find in a particular design that you need to fix before this product can see the market. The deeper you go into this pipeline, and the later you find a mistake, going back to the drawing board is increasingly more and more expensive. So what we do today is we freeze the designs very early on, in early phases. That's why we have this first curve very low. And as we go to preclinical and clinical trials and regulations, everything that can go wrong starts getting wrong. And that puts people at risk, and also the companies that are behind the investment that goes behind is put at risk. And then what we are proposing is that perhaps if there was a way to actually use secondary data together with models and simulations, so we can actually generate virtual populations where we test these interventions early on, we can do, because it's all virtual, we can do a much more exhaustive search that optimizes those interventions and also test them across a much larger range of operation that you could ever do in a sort of physical world. That doesn't mean that we don't need animal or clinical testing at some point, but what we suggest is that it needs to be used as a confirmatory source of evidence rather than as a discovery source of evidence. And that you would go to this phase with a lot more confidence in your innovations. So hopefully what you do is you kill out, you sort of sift out a lot of innovations that will anyway never make it to the market. Now, is this new? Well, to be frank, as an engineer, if I look at what they're doing in the automotive sector, in the aerospace sector, they've been doing that for quite a long time. And if you look at, say, in the 90s, a car in the 90s and a car nowadays, there is a massive improvement in the products that we are generating. But it's not just the products, it's also the processes. We don't do aerodynamic tunnels anymore, we do aerodynamic simulations. We tend to use virtual prototyping rather than physical crashes of the cars. And we also start using more and more AI into this space as well in autonomous driving. If I show you 30 years worth of innovation in a sector that I'm going to talk a bit more afterwards, which is in a certain treatment for brain aneurysms, these are coils, stenting, and flow diversion devices, is effectively a bunch of wires of pretty much the same material over 30 years of time, with a still nearly 20% complication rate, 3% mortality rate, and we can do the same things that we do in the aerospace by modeling and simulating in this area. Now, you may say, well, but aerospace and automotive, these are a lot easier than healthcare. Well, that's to some extent true. I don't want to simplify that, but what I'm trying to say is if you think the aerospace is mission critically, highly regulated, is multi-scale, is full of uncertainties as well. And the theory, at least in this area, is that the more complex the system is, the more you need actually modeling to understand the emergent properties of all of these bits and pieces interacting with each other. So actually the complexity is a reason to use this, not a reason not to use it. So what do we need to model, and what is this in silico technology? Well, it's about modeling pretty much everything you can. So modeling virtual populations, modeling the influence of the clinicians if they are involved, modeling the devices, modeling the interaction between device and the host organ where this device is implanted or the drug is acting, and then finally having mechanisms to relate those to clinical outcomes. And today I'm not going to talk really about One Health because you will realize that this is actually quite complex in its own right. But imagine now that we could also model the influence of social determinants, for instance, of weather and environmental determinants of activity in the city where these people live, certain exposures that these people have just because of the geography where they live. All of those things could be potential factors that you could bring in. So now, I hope by now it's clear, but just to emphasize, I'm not advocating that we need to remove the need of randomized controlled trials. What I'm saying is this is a way to de-risk randomized controlled trials and to be smarter in picking up the right innovations. So the way I see it in the future is what we will have is more proportionate and adaptive risk-informed frameworks that will incorporate and weight in some way all of these different sources of evidence, the ones we had before, plus computational modeling and simulation into a more integrated framework. You cannot do this without access to digital data for secondary use. And the better your data is, the better basically your models will be. Now, there are two aspects here, and this is to advocate for mechanistic models in particular, because when we talk about data, we tend to think about AI, we tend to think about data-driven models, but there is actually a certain trade-off between how much access to data you have for a particular problem. So you can have situations where you have no data access or very poor, and lots of data. And we heard today from a number of the talks that a lot of the regions are not completely data ready or data integrated. I was hearing today the comments that in Europe we're a lot more organized in terms of data access. I can tell you as someone living in the UK that it's still very problematic to have a full integrated set even within the national healthcare system. But then you also have a lot of knowledge from what we call first principles or mechanisms, the biology, the physiology, the physics, the biochemistry, the anatomy, right? And the reality is that we are never in a situation where we understand everything about the mechanisms or where we have an infinite amount of data. We are always navigating somewhere in this middle space where we have to use both of them. And I'm not going to go into detail about this, but there are some computational sociologists, actually, that have made predictions that with the current progression of data access, the increase in data will not solve the problem. Putting a complete digital platform will not solve the problem because data is growing exponentially, computational power is growing exponentially at a slower rate, so there is going to be a moment where we will have more data that we will be able to compute. And the only way to curb this course of complexity is by incorporating prior mechanistic understanding because the systems that we're trying to understand are ever more complex and the complexity grows factorially. Now, it's quite interesting that a few weeks ago, someone pointed me to a person who is actually in the University of Manchester, recently moved there, called John Williamson, who is developing or promoting this area of evidence-based medicine plus, or what they call evidential pluralism. He's a philosopher himself. And what they're saying is that the current approach of only using randomized control data or sort of association studies, even if you try to do it through causal inference, shouldn't be the only way, that you need to incorporate mechanistic understanding from other sources and other types of studies. Okay, let me just give you one example about this. So this is a full in silico trial that we ran a couple of years ago in the area of brain aneurysms. So, and the question that we were trying to answer is this: can we use in silico trials to replicate and perhaps even expand findings of conventional studies, conventional trials? So we took as an example, a bit like Moira did with the AMR and other colleagues did earlier with Femtech, we took brain aneurysms. So this is an enlargement of the vessels in the brain that produces an hemorrhagic stroke and is quite lethal. There is a number of ways of treat that with craniotomy in the case of clipping, and with minimal invasive therapies, the other ones. But there is a whole zoo of devices that are being developed at the moment for treating this condition. There is probably about 40 products out there. Imagine each of them going through what I'm going to explain in a moment. The other issue, which is quite important, is that if you look at the different types of products that have been used for this condition, web devices, flow diversion devices, these are just different technologies. Their lifespan in the market is sometimes much smaller than the duration of the time that it takes to actually produce them. So it may take you 12 years to produce the product, and it may be on the market only for 5 years before it's faded out by something else that came up. And as technologies accelerate, we will have this problem of generating evidence at a much faster pace. And that's why I think having a digital enablement will become critical. So the way this device works is you have the aneurysm, which is enlargement. You don't want it to burst, so you put a flow diversion devices. That's what it says on the tin. Diverts the flow. It stagnates the flow within the aneurysm, produces a thrombus, and then somehow disappears, or it just gets out of the circulation. So this device, the pivotal trial that led to its marketing is called the POOF trial. It took 8 years from design to publication, 6 years of following up, whopping number of 108 subjects, and 30 to 40 million pounds investment to get there. They claim, it's a device from a company, from Medtronic, they claim that this is one of the most studied flow diverters in the world. If you compare the first randomized controlled trial of POOF, which was 110, say, subjects, and Premier, that was for the small aneurysms, another 145 or thereabouts, and then you add Aspire, which is a registry. So earlier, one of the speakers in the morning was saying that sometimes agencies give a conditional approval. They say, well, we allow you to go to market, but you need to keep doing measurements, right? So this is an example. The Aspire was a registry that with the other 2 studies, they were led to the market, but then they had to keep doing extra measurements. So if you put all the 3 studies together, that took about 8 years, 10 years, and that's 500 subjects. That's all the evidence they had to go to market. And just a regular, decent hospital puts at least 100 of those a year. So what we did in this publication is demonstrate that reproduction of results. So what we show is that these are the results of the 3 trials that I was talking about. And you see the dates of them and their numbers. You see the variation between them. So these are 6 months outcomes, 1 year outcomes, and 5 year outcomes. These are 1 year and 7.8 months. So it's essentially around 75%. Our study, if you trust me for a minute and you just do the average of these 2, you have about 75%, is spot on with those. This took about 3 months to run, okay? Now, why we have these 2 different numbers and not 75, which is the average? Because we could generate scenarios of physiological variability of hypertensive and normotensive conditions, which is effectively a stress test that you wouldn't ethically be allowed to do in a real trial. So what we show is that just by changing and making all of the patients normotensive or hypertensive, you have a 15% difference in the outcome of this product, just by changing the physiology. These studies, because they have a very small number of subjects, they couldn't even explore that, so you don't even know that. So how you do that? Well, you create from, say, electronic health records, and that's another point as well to Paul. Electronic health record is a very generic word. So for instance, I need to do this access to the 3-dimensional images in DICOM format. Sometimes what they store in the electronic health records is just the measurements of diameters and lengths, which is like a derivative measure. So we lose a lot of, I think someone was mentioned that we lose a lot of this data on the way. But say that we have a very large database, we can then, for each of those subjects, produce a virtual implantation of the device, look at a relative outcome. This is a metric about how much flow we have reduced. We can look at what happens with different physiological regimes. So these are waveforms in the carotid artery of blood flow in rest and in exercise conditions. So we took the first patient and we show a virtual rest stress test, and we see that the outcome is different. And you can then put different competing devices and compare them against each other. And because we can do all of the interventions in every single subject, we don't need randomization, which is one of the premises of RCTs. Okay? So how do you get all of this data? Well, you get it from regional records. This is why this needs to be super good and super, multimodality as much as possible. You get it from population data, things like UK Biobank, and you get it also through device specifications and information that comes from the manufacturers, which I think is the next frontier. It's not only that we share data from the health systems, but also to what extent there is a responsibility as well from manufacturers to make some of their data available so we can do faster progress towards better therapies. So just to give you an example of the challenges and the sizes of some of those data sets, 2 years ago, we made a request for one of our local hospitals to access to data for secondary use. 2 years later, I still don't have access because of all the practical issues, but I have some high-level statistics about what I would hopefully get, okay, one day. So to show you this, in a period of about 10 years, there are 36,000 subjects with data to do studies like the one I talked in a single hospital. That's several orders of magnitude bigger than the randomized controlled trials that I was talking about. But you also see some of the issues. For instance, ethnicity is very underrepresented, some ethnicities. Problems like, for instance, nobody will believe that there is only 2% of people with diabetes in this population. This is self-reported diabetes, not the actual one. So curation of the quality of data is important as well. And the other thing I want to say is not just about this sort of data, it's also about access to data like biobanks, like UK Biobank, or studies from randomized controlled trials, so we can do comparisons against those. Okay, I'm going to emphasize that this is really important. The UK has recently made an announcement about creating a 600 million investment in what would be the equivalent to the European health data space. They call it the Health Data Research Service that will provide a single point of access to data for health data. And the way that people are thinking in the UK is that these data sets will become what they call a health data sovereign asset. And I believe that one of the problems that geographies that don't have a good setup for this will have is that the ability to generate high quality evidence about their demographics will be hindered to a large extent, right? I'm going to finalize with a couple of ideas. One is that you could use the same sort of technologies to look at off-label uses of these products. So this device that I was talking has only been approved by a sector, and you don't want to run a full trial just to look at whether the same device could work in another part of the same brain, if you could do that computationally. And we have also done some work where we have shown that you can do, working with health economies, you can do things along the lines of health technology assessment and cost effectiveness, because you can produce estimates that can be useful for doing health economic analysis as well. And we've done quite a lot of publishing of those. And one of the interesting things is that you could also find that, for instance, this particular device in this type of anatomies compared to these ones, and you see that there is a part of the brain that is missing here, a part of the vessels that is missing. This is healthy people. It's just that some of us have variability. But it turns out that this variant is more prevalent in Hispanic and people of black ethnicity. So look at the results of the difference in efficacy between these two scenarios. Is half the efficacy in those subpopulations that corresponds to a specific ethnic groups compared to the other variant that is most prevalent in white Caucasian people. So we will be able to, using these sort of technologies and access to data, start unpicking all the issues related to health inequities that some of and inequities in care provision that we're seeing today. I'm going to leave it here because I know we are on time, but I hope I sort of helped to understand that even with only health data we can do a lot of things, and wouldn't it be great if we could actually expand to some of the other data sets that we're told today. Thank you.
Thank you so much, Alex. And I open the floor to questions. Do we have any questions? No raised hands? All right. Then maybe let's do it like this. If you could summarize with one sentence or one key point that you want to bring across, so what would it be for you, Paul, on EHDS?
Okay. I guess that we should be realistic. One Health sounds very ambitious, very promising, but we have to be realistic and realize that it competes with other goals and needs also. For example, maintaining privacy and trust. And this is why the EHDS will stay, should be thought of as a health database and not a health space and not an everything space.
Absolutely. Moira?
Sorry. I think for me, it would really be that I think, you know, when we say One Health, that focusing on this idea of collaboration, coordination is critical, that there's a lot of opportunities from for learning from each other, not just, you know, in terms of working in different sectors like human health versus veterinary health versus, but actually in terms of interdisciplinarily as well. And so I think that the more we can bring people together and try to get everyone talking in the same space, the faster we'll be able to develop and hopefully bring, you know, we're all starting from different starting points, and so bringing all of these different sectors up to trying to be able to share equivalent data, the fastest way we can do that is by learning from each other.
Thank you. Alex?
So I'd like to say what Paul said, but in a slightly different way, is that we need to learn to pick the battles in this area in the sense of finding exemplar problems or challenges that have an important return on investment, because the reality is there is a massive technological debt to realize most of the things. Even if the regulation was correct, someone was telling earlier there is an implementation component as well. And I think we're underestimating the implementation. We're trying to develop DHL, you know, FedEx and DHL and all of these services when we still don't have tarmacs in our highways and we haven't invented the airplane, if that makes some sense, the analogy. So, but we need to look at what are those exemplars that will help us to realize the importance of laying the tarmac and get the return on that investment so that we unleash some of the other options as well. And I'm not saying that the example I gave is the only one, but I think we need to understand what is failing in the current systems and what is the cost of not acting. Because I think we put too much emphasis in the impact of sharing data, the problems that come with it, but not the impact of the fact that we are spending a lot of money in healthcare that we are not really capitalizing because we create silos of data all over the place. And that money we are spending anyway. So it's how we do that connection and what are the challenges that we need to address that will help us to get there.
Yes, Paul?
Just to come back, yeah, I agree completely. And with regards to the EHDS, agreeing on the text was the easy part. We know it wasn't easy, but that was the easy part. To get it to now to a level where it produces something that is minimally resembling what we want will be a mammoth effort that will require funding for all these entities that need to assemble this data and make it available. That will cost money and time, and without that, a law alone won't make it happen. And the second issue escapes my mind because I'm tired. Sorry, leave it there.
We all are full, I absolutely understand. And to sum up, the work starts just now. I'm already looking forward to the next year's symposium on EHDS, on the implementation challenges. And thank you very much to each of our panelists. Thank you very much to Paul and colleagues for having organized this excellent conference. And thanks to you for being part of it. And enjoy your evening in Brussels and have a safe trip back home. Thank you.
Very short and final housekeeping announcement. We have a small tradition. Afterwards, a few of us go for a drink in a cafe Brewdog around the corner. So anybody who wants to help us continue the tradition is welcome. Thank you.